We are now in the final part, the final concluding session of the workshop. What I had done was to ask Dr. David Pryor, who many of you know or know of. He was for many years the Chief Medical Officer for Ascension Health and had wrestled with, as a large faith-based system, many of these same issues. And I asked David if he could comment a bit on what he's heard over the past day and a half and how this fits into his views of the world and how Ascension had dealt with some of these issues. So we will turn next to Dr. Pryor, and then we will conclude the workshop with just a few wrap-up comments from Dr. Kirsch, who was, as I think has been said a few times already, the person who requested the workshop in the first place and had reached out to the National Academies to make this happen. And I will probably throw in a few comments as well. So with that, hopefully we won't have any technical glitches and we can turn it over to Dr. Pryor.
Thank you, Ken. Can you hear me okay?
Read you loud and clear.
Okay. Thanks for allowing me to participate and to make some observations. I have no financial conflicts. I have worked with the National Academy, the National Quality Forum, and the VA in a number of different roles, both currently and in the past. Ascension is a community care provider for the VA in a number of markets and strongly committed and supportive of the VA system. My comments are really my own and not meant to represent any of these organizations. It was a pleasure to listen to the outstanding presentations that were made and the obvious skill that the Planning Committee and the National Academy staff brought to organize the workshop. I'm particularly pleased to be able to comment because of the importance of the topic and recognizing the responsibility and the desire of everyone to improve patient-centered approaches to optimizing veterans' access to healthcare services. My comments today are not directed really at trying to summarize each session. Those of you who are familiar with the National Academy workshops know that this will be done in the consistently excellent fashion that the staff at the Academy always brings to a workshop summary. Rather, I've been invited to try and contribute my observations around consistent and common themes that I've heard, as well as to provide my own commentary and thoughts. The first key theme we consistently heard is that the issue is complex with multiple dimensions and that there is no single measure like wait times or a single approach that will deliver on the goal to our veterans. One size will not fit all. We are also not starting from ground zero. There has been extensive work within the VA and other systems, previous workshops and roundtables, and outstanding outcomes that have been achieved in specific examples within the VA as well as in other system examples. There is much that we have learned from those examples, and that should inform our approach. The complexity and multimodality of the issue suggests that the overall goal should include the establishment of a continuously improving system to improving patient-centered approaches to optimizing access. This might seem like an obvious comment, but I would consider making it explicit and a necessary requirement of the design. This is important because it impacts the improvement system design itself and what you measure. It is also important because with such a complex issue, it is unlikely that there will be universal agreement across all stakeholders with veterans advocacy groups, congressional oversight committees, and VA leadership. And yet some agreement on how to proceed is essential to engaging the support that is required for moving forward. By recognizing that this will be a journey, the dialogue becomes not about which of the issues should be addressed, but rather shifts to the order in which the issues are addressed and makes the required compromise easier because it's not about if, but rather only when. We've heard from multiple speakers about the importance of both actual and perceived assessments. It cannot be an either or, but rather must include both. They are intimately related to each other, and true improvement cannot occur without measuring both and understanding the influence each has on the other. Actual and perceived assessments are further complicated by multiple other issues. There are condition-specific issues such as mental health, population-specific issues such as homelessness that are present in the services that are provided, and the measurement of access to those services of both. There are issues around continuity of care, integration of care across providers and systems, affordability of care, social determinants of health and equity, trust in the provider, and implications on structure, process, and outcome assessments. Improving access is important, but as we just heard from the advocacy panel and from a number of other speakers, it is probably more important that the improved access is to the right resource, the right person at the right time in the right way, rather than simply measuring access to any resource. Access has many aspects. For example, the availability, accessibility, accommodation, affordability, and acceptability, as we heard this morning. Other frameworks like the AIMS and the Crossing the Quality Chasm report incorporating quality, effectiveness, efficiency, equity, timeliness, and person-centeredness, or recognizing the need to provide care that responds to the emotional needs and builds trust. Within any specific variable measurement, there are issues around each specific measure: validity, reliability, reproducibility, and so on. Measuring what's available versus measuring what matters, and the balance between measuring enough, but the parsimony required to make the veteran and the care provider response burden reasonable. The conclusion seems inescapable to me that there are far too many areas and issues to address at once. The approach should incorporate a framework and a process to prioritize. Another theme we heard relates to how we might think about that prioritization. There is a need to address overall performance of the system. There is also a need to improve specific programmatic access. There is some consistency that we heard that the overall performance should probably be addressed by veteran perceptions to access the care, perhaps with a very limited set of actual care measures as well, although there is a risk of worsening appropriate access in using actual measures, particularly if these are used for incentives or overall performance grades. There was also some consistency that access measurement for improvement should be more locally driven in specific populations or settings. This recognition that access assessment has these two different goals, global assessment and specific programmatic improvement, is fundamental to how priorities are set, who is setting priorities, and where priorities are set. Developing this prioritization framework and how access is conceptualized and measured may ultimately be more important than the development of the measures themselves. Some balance of impact, speed, and difficulty to implement will be important to understand. It may be worth considering whether the characteristics of the framework might be further specified to identify how much can be done at any one time, and then back into what's actually done at any point in time. The VA has often used programmatic improvement approaches based on pilot approaches and then spreading these pilots if successful. This not only makes sense, but underscores the need to separate out global assessments from specific programmatic improvements. It is important to integrate all stakeholders in the construct, these two purposes: overall assessment and programmatic improvement, and particularly to secure the voice of the veterans themselves, or their advocates in this process. The veteran voice will be key in engaging all stakeholders in the framework, the overall program assessment approach, as well as in the specific program improvement goals. The veteran voice will help in the design of specific program interventions and to align care providers, a key characteristic, as we heard, to capitalize on the provider passion and minimize unintended complex system consequences to specific interventions. One could envision an overall process where multiple specific programmatic initiatives are developed, spread, and ultimately impact on improving the overall assessments, essentially achieve one veteran at a time with personalized patient-centered care. There was discussion about specific programmatic capabilities where the VA excels and is the recognized leader in this country, if not across the world. The spinal cord injury programs, PTSD programs, for example, and others are examples. Why not focus on improving the best programs still further and using that experience to improve access everywhere? A rising tide raises all boats is a clear winning strategy in quality improvement generally, and probably applies here as well. The most rapid improvements across systems occur by focusing on and improving the best, not by raising the worst performers to the next level. We heard a number of examples of novel specific interventions. What struck me was how powerful these improvement stories were and how they were always in specific programmatic interventions. This would be another approach to going with the winning strategy. Specific interventions in specific populations, as opposed to focusing on the specific VA programs. In other examples, we heard about specific VA populations. Access issues could be considered for these populations with established or developing programs. For example, complex patients, blinded veterans, women, or populations with specific equity concerns. We heard great examples around expanding access capacity. These are best understood within the specific programmatic improvement, although many lessons learned will be extendable to other areas. Understanding how to incorporate preferences in one area will likely apply to others as well. I particularly liked the supply-demand constructs because they naturally lend themselves towards mathematically prioritized objective improvement interventions. In summary, the voice of the veteran is key and has to be the foundation around improving access to the right resource, getting buy-in to separating overall VA access assessment versus a specific programmatic improvement framework, and in identifying prioritization framework and strategies. Key components of improving access are recognizing and improving access to the right resource at the right time, provided in the right way. I could imagine a system analogous to help desk technologies with initial call, triage, and subsequent different level escalation and handoffs depending on issues. I can imagine virtual or real assistants that culturally match the desired need of the veteran initiating the contact. I can imagine an AI-driven, continuously improving system that engages the veteran directly in the scheduling process through a website or visually impaired friendly kiosk, where the veteran answers a few questions and either immediately goes to schedule the visit or the request is escalated, just like sophisticated call centers, ultimately perhaps to a primary care or specialty care provider or both, to determine the right resource, how it should be provided, the timing, and even might itself end up being a telehealth visit if urgent. This kind of system combines access with urgent improvement strategies. The performance of the system against these recommendations determines actual performance, and overall perceived appropriateness and timing is also assessed. I could then imagine how the disposition after the physician visit includes the traditional diagnostic evaluations and therapy, but also the next visit follow-up time, explicitly identified continuity and integration requirements, and veteran and clinician assessment of the experience so that the access performance assessment is directly integrated into the care delivery process. Integration of other data about the system or context and the individual patient could provide the data inputs to enable AI analytics to continuously improve the system around scheduling, key question identification and responses, and also integration and continuity issues to better anticipate and improve needs and the planning and matching of resource supply with demand needs. Ultimately, access is an integral feature of the care delivery system, and the separation of access from other important system elements is arbitrary, although perhaps required for improvement design. There is no current system like this anywhere in the world, and the lessons learned in the VA system would be broadly applicable. In the final analysis, such a system is what our veterans have earned and what we all want for ourselves and our families. Thank you.
Thank you, David. Having a minor technical problem there. There's a reason why I asked you to make comments at the end, and I think it's obvious to everyone why that was. Not only were your comments comprehensive and extremely thoughtful, but quite eloquent. So thank you. Indeed, the staff, maybe you just want to substitute David's comments here for the summary that needs to be prepared.